If I could have Rhee come up on stage. We're very excited to have him. Q is the, I can barely read this. He is the Chief Health Officer of IBM and has global responsibilities for Watson Health and ensuring a culture of health at IBM. His task is to give us an overview of the capabilities of AI in our space. Following him, Ralph Gonzalez is going to join us from UCSF. He's the Chief Innovation Officer at UCSF, and he's going to talk to us about the challenges that he's been dealing with from a clinical perspective. And Ben Levy, who has 20 years of experience as a Silicon Valley veteran, will moderate the session. He actually is the chair of the San Francisco Artificial Intelligence Conference. He's very knowledgeable in the space and also runs Bootstrap Labs, which is a VC that focuses entirely on AI. So I think we have an extraordinary group of people who really get us focused on what AI has and what implications are. So Q, who, by the way, has endured incredible challenges to get here. Last year was the storms in South Florida that shut down the East Coast that didn't allow him to come. This year he had feet and feet of snow and ice in New York. He got stuck in the tarmac, got in at 3:30, and we're really grateful for him making the effort.
All right. Yeah, I think I have it here, Stefano. Yeah, we're good. And thanks, Stefano, for being patient with me and inviting me again. I appreciate that.
Thank you.
It's a real honor to be with you. And I loved the prior session and how you talked. I wish I was wearing pink socks, so I'm looking forward to trying to get some.
Let's take care of that.
Oh, you took care of that. Should I change right here? You could change right here. Thank you. So, look, telling your story is a very important part. And while I listened to the startups, and I heard their stories, and I want to tell a little bit about mine, but I really want this to be an opportunity for me to listen and learn more than talk. But I do, when it comes to AI, and when it comes to my story, I think about myself about 10 years ago with this picture. Working in an underserved community in Baltimore as a primary care physician, as an internist and pediatrician, and being challenged with the EMR at the time, and looking to serve the patients that we had, many of whom had a broad range of issues, chronic diseases, the opioid epidemic, all these other issues, and then being in this situation and not thinking, not even imagining 10 years from then, I would be here in front of a bunch of orthopedic surgeons talking about digital health and being the chief health officer for IBM. So I have to admit, it's amazing how your story leads you down different paths, and I'm looking forward to having a number of other paths with the people I'll meet today and with you and Stefano. So as I think about what I'm doing now and what we're trying to do in AI and how that relates to what I was faced with then and what we're all faced with, and many of us are faced with, this big data challenge. We don't have enough time. We have too much we need to know. And the science keeps getting updated all the time. And so it's humanly impossible for any person, natural intelligence, to maintain and be able to keep track of all that information as you do your best on behalf of that patient or that family with the patient that you're trying to serve. I reflect on myself and my father and how he has multiple medical issues and how I'm challenged to keep up to date to make sure that he's getting the best care. I trust the doctors he has, but I'm still looking for that science. So this idea of AI supporting humans we're in a new era. And so at this early stage of this era, you have startups. IBM and Watson Health likes to say it's a startup. It's a little bit of a bigger startup, perhaps. But we're only 2.5 years old. And as a pediatrician, I think about our terrible twos when we're going through it. And we're going through quite a bit. And it's an exciting time to be working in AI. So the way I like to simplify what we're trying to do is, if you think about healthcare and you look at the history of medicine, and I remember in undergrad when I was at Yale, I took a class in history of medicine, and I thought about, as I thought about becoming a physician, I looked at the history, and what is this? This is one of the first stethoscopes that was created. Doctors used to listen with their ears when they listened to hearts and lungs and abdomens. And then Dr. René Laennec created one of the first stethoscopes about 200 years ago. So what I like to say, at a simple way, what AI is meant to be, it's a big data stethoscope. It's meant to bring personalized insights from that big data, personalized to that individual, whether it's a patient, a provider, a payer, a government, You think about how things are consolidating in healthcare. I love the feedback that was given. I mean, I see the same thing. So we are creating together big data stethoscopes. And perhaps it's a bit physician-centric, but this is a physician-centric group, so that's what I'm referring to here. So this is an important slide that I think highlights some pieces. And then next I'll talk about some of the competitors and somewhat of what's going on in terms of the different stakeholders. But this ultimately is, with meaningful use, and I was in the federal government with the Recovery Act and the creation of ONC and the efforts around meaningful use. And I remember hoping and believing that some of the work we were doing was going to lead to better health outcomes or efficiencies. But now all that data is in formats, and when I worked in community health centers, when I came right out, it's all paper-based. And we went through a number of transformations with EMRs in the different health centers I worked at. But it's about that data. It's about all that data now being available. It's big data, but big data alone is not sufficient. And it's also about all these stakeholders. So as you think, and I like to say, if you're not at the table, what are you? You're probably on the menu. And in many ways, I would suggest that providers and physicians have not been at the table of healthcare. They have not been there to be able to participate in the transformations that often occur to them, not with them. And so there's a huge, important opportunity to think about those stakeholders. I call it the 7 Ps. I think about all, you just were mentioning Aetna and CVS. That's a payer. You were mentioning employers. There's a group of employers, the Health Transformation Alliance. About 40 plus employers, about maybe 6 million covered lives coming together. That's a form of a purchaser. If you think about providers, consolidating, Ascension, and Providence, and all these, these groups are consolidating. They're trying to work in this system. Policymakers are trying to figure it out. The FDA, all the FDAs. As I look at IBM, I get to see amazing policies and regulatory perspectives all across the globe. And it's fascinating to see whether it's Japan or Germany or the UK or Kenya, and see how different things are approached as it relates to digital health. And then product manufacturers, the people who create the products, the Medtronics who are here, or the pharma companies. And then the pioneers, the people here who are looking to find that place where they can connect and disrupt. So you have to think about all these different stakeholders, and it's complicated because so many have so much to gain and so much to lose as things transform inevitably, and things do restlessly change in healthcare. And ultimately, we do have a common goal to help patients, to help those populations. And we do have this big challenge in big data to translate the variety of data. And so I would suggest, and I saw this firsthand serving in underserved communities, social determinants of health, health literacy, the broader issues of access. What I like to say health is about home, education, access to healthy choices, labor and employment, transportation access, a holistic view of health that's physical, mental, social, purpose, and really connected. In healthcare, we've kind of missed a lot of that data. We don't have access to a lot of that information. That data that I believe has a huge impact on health outcomes, on improving the health of populations, which is all we want for those patients, for those populations. So the variety of data you bring together is very important. The volume of that data is extraordinary. Previously, we didn't have the capacity to store all that data. Now that exists. The velocity of that data, if you think about all the wearables, and I know Daniel Kraft will talk about it, all the different instrumentations, all the opportunities, I believe there should be eventually a home health system, not just a home security system. Think about all the data that's collected in some kind of way, and you need to get consent. But you could see, as I think about my father living in DC with my mother, and they're relatively old, I want to get predictive insights to when they might not be feeling well. And I suspect their home security system has some insights based on their predictive patterns of how they move and how those different monitors and those surveillance things go on or off, or how often they use the kitchen or go into the kitchen, or how long they sleep and stay in their bedroom when they're supposed to sleep. So there's many opportunities to think about the velocity of the data that occurs. And in healthcare, we only get maybe 10 encounters, or as I look at the data that we have with Truven, the average number of claims you get per person might be 15 to 20 a year. And there's so much more that happens in health beyond just those claims. The veracity of that data, junk in leads to junk out, and the value of that data, which of course we're all facing. So to me, this is a key piece. How do we translate and leverage AI to translate data into insights that are personalized to all those different stakeholders? We all are at the table of transparency, hopefully, of looking at that data together and figuring out our respective roles. Some people are frightened by that because they think their part of the pie will get smaller. Some people think, and get excited it'll get bigger. So there's a huge opportunity to leverage AI to bring truth and insights from that big data. And these are the key decisions people have to make. Where am I going to put that data? I mean, the fundamental thing about healthcare is trust. And the fundamental thing about AI is about trust. Do I trust the AI system? If I, as a physician, am going to leverage an AI system, how do I trust that system? So where do I put that data on? Where do I put all that personal health information? What cloud will I put it on? And of course, there are a number of people looking to have that data that you have access to for your patients on their cloud. They're looking also at what content you're combining there, the variety of data that I told you about. That's so essential, publicly available data, proprietary data. The variety of data, I think, is so essential to get the right insights. And then what cognitive or AI systems can be on top of that cloud to bring the right insights? As we have startups and others, how do you create an open platform where people can innovate, can make mistakes, can continue to iterate and improve their AI offerings? And then who are you going to partner with? Who are you associated with? And how does that play an important role in the trust? And then the clinical evidence. And we've been highlighting this more and more at IBM and Watson Health because we're a technology company that's becoming a healthcare technology company. And in many ways, we have a number of healthcare professionals that we have recruited and we continue to recruit because we recognize in order to be effective in this space, in order to build that trust with you, in order to be connected, we've got to translate the technology into a healthcare situation and vice versa. So this is basically the fundamentals of AI in terms of what a human can do and what an AI system can do. And this is very important to think about, how you can be helped addressing the issues that frankly you shouldn't be doing. Pattern recognition, broader things of locating knowledge, locating that study, thinking about the fact that I just came back on the flight and I'm a little tired. And there are moments where we're all tired. How can we leverage an AI system to provide that actionable insights, that augmented intelligence to the provider at the point of care, to leverage that big data into key insights that are personalized to you? And this is pretty much the last slide. What I want you to see here, as we think about AI, and a number of people have mentioned that AI is potentially the end of humanity, and there is a huge responsibility we all have in AI to speak up, to state a perspective. And here's a little bit of the way we've thought about it, IBM has thought about it, this idea of what is the purpose of AI? It is not to replace people, it is to help people. So we call it augmented intelligence. That's a very key piece. And some folks, now, will it replace some activities that humans do, like orthopedic surgeons do, that are fairly time-consuming and you want more time with your patients? Perhaps. You have to tell us what those things could or should be. But ultimately, it is to help people be at the top of their capabilities, the top of their training. There is a transparency that's essential here. And if you're working with AI companies and partners who aren't being transparent about how the system was trained, what data was being used, what biases I believe that are part of that data, that's a very important piece. Transparency, a glass box, not a black box. And then the third area is what skills. How do you bring these together? And this will change, and I believe in the future, and we're already on this, that in the same way that a healthcare team has a broad diversity of healthcare professionals, a nutritionist, a social worker, a pharmacist, you will have data scientists embedded in that team. And their responsibility, machine learning experts and AI experts, their responsibility would bring insights out of that data that you could have never thought of. I didn't understand there was a whole science around machine learning and AI, and I'm now encountering those folks every day, my colleagues at IBM. It's extraordinary what they know, how they were trained, and how they bring something out of that data is not beyond the traditional regression analyses, beyond the traditional health services and health economics research. So that's a very important piece as well. The last visual I have is, this is a demonstration. Now, do I have right now a demonstration of AI in orthopedics? This is why this group is coming together. But this idea of bringing data from an EMR, bringing it out, and then putting, with a huge chart, a cancer patient chart, bringing the right criteria and data into a system that helps you find a clinical trial, to help you find the right treatment recommendations that should be based on the most recent literature or guidelines that are customized, that might even personalize to what you are uniquely interested in. It might be customized to your publications that you think are top-tier journals versus someone else's. And those publications you value, or those guidelines that you value, or that type of practice pattern you value. But this idea of bringing it at the point of care is what we've done with Memorial Sloan Kettering, and it's just a demonstration with transparency, showing the articles, showing the information, and letting the human make the decision. And so as I think about the health disparities time, and I think when we build this work in this world of AI, with AI, we do have to think about the implications of how this will impact health disparity populations. Places where there aren't orthopedic surgeons, where there aren't enough oncologists. And it'll be challenging to determine what the ethics are as it relates to how we endeavor to support those patient populations who have cancer, who have orthopedic issues, where there aren't the specialists that we have in San Francisco. So that's pretty much a little more than my 10 minutes. But I also brought a bunch of clinical evidence. This is very essential. I'm not going to go over it. But it is important that we build the clinical evidence. One of the challenges with an AI system, if it continues to learn and improve, it's not like a drug. It's not static. So doing studies get more challenging because you've got a system that continues to improve. Also, the complexity of human decision making is a lot more complicated than the people who definitely take a drug or don't take a drug. So there are lots of opportunities to evolve the science as it relates to AI and the clinical evidence here. So, thank you. Can I change my socks? I'll change my socks.
We'll look forward to seeing those socks a little bit later. Ralph Gonzalez.
Stay here.
Is that on? Here we go. Great. So I'm Ralph Gonzalez, and I'm a general internist by training and a clinical researcher, quality improvement researcher. And just over the last few years, I've taken on a role as the Chief Innovation Officer for UCSF Health. And Stefano asked me to give you a perspective from the delivery system about where are the pain points, completely AI agnostic, that we are focusing on as a delivery system. And you may wonder or ask, why would you ask a Chief Innovation Officer to talk about that? And so I just want to describe that the role that the Chief Innovation Officer plays at UCSF Health is one that is embedded in the delivery system and trying to innovate from the inside out. So by understanding our problems at the front lines, what are the physicians and nurses and staff dealing with every day, as we come up with solutions for those problems, that's where the innovation emerges. So I think of it as inside-out innovation. I oversee our continuous process improvement efforts, and so helping to make strategic investment decisions from the organizational perspective about how to train and develop our people, and then where do we invest in programs and technology that is going to have a direct impact on UCSF Health, is where I sort of spend a lot of my time with a lot of different department leaders. And so to cut to the chase, there's 5 areas, I think, that emerge as particularly major areas of investment and concern for UCSF Health. And it's no surprise that the companies that were up here just a few minutes ago are all working in this space. And it probably speaks to why they're being as successful as they are. So the first is the cost of care. So healthcare costs are spiraling. Much of that rise in healthcare costs has been attributed to some of the advancements in technologies and treatments that academic medical centers are producing through all of the great research we're doing. But the other key piece with the cost of care is that we don't have a payment system that covers the cost of care. And so in a fee-for-service, if we were purely risk-based, like Kaiser or some of these other large health systems, then what you invest in makes total sense. But in a fee-for-service system, we're often dealing with treatments and procedures that are not being covered adequately by Medicare and Medicaid, which covers 40% or represents 40 or 50% of our population. And so we expect the commercial payers to then cover the balance sheet there so that we can break even. And so what are the root causes of the cost of care problem? So number one, the new treatments. So when you have life-saving treatments like CAR T cells that are coming out now, where we've taken an 80% mortality in lymphoma patients and leukemia patients and turning that into a 20% mortality, you have to offer that treatment. But you can't force the payers to pay for the full price of that treatment, which is about $500,000 per treatment course over about a 6 to 8 week period. So you have to make decisions around the value proposition for those types of treatments and technologies, and you have to balance that across the entire population that you're serving. And so tech companies and AI needs to take into account what is the value proposition for the work you're going to do, and ideally, will it help to lower the healthcare costs for that area that it's working in. The other key piece is that our safety and our quality events continue to be a problem in the hospital, which prolong length of stay, and we haven't gotten a good handle on that. We've seen some modest reductions, but in terms of a space that can help us reduce our cost of care, one of the key root causes is adverse events and safety events in the hospital that keep patients longer than is necessary. And then end-of-life care continues to be another key space that we're focusing a lot of efforts in. When you look at healthcare costs for our population, a big chunk of those happen at the end of life, and some of that seems logical because, at what point do you decide it's end of life, or are you still saving lives? That's where I think having better decision-making tools could be really helpful to make those decisions better. The second area is physician burnout. And anything we do today, if it contributes more to physician stress or staff stress, is not going to be adopted into the delivery system. And the physician burnout piece has been particularly accelerated with the advances and the improvements in data that we've seen with the EMR and with all of these new tools. And so doctors right now are spending, especially if they're ambulatory doctors, are spending 1 to 2 hours outside of the office documenting and managing population-level data that's coming in from patients through their electronic portals for every hour that they're seeing patients in the office. And then you add on top of that the changing complexity of the patients as we continue to see our populations age. And you're taking what used to be sort of a 3-problem appointment time and trying to manage 10 problems in that 3-problem appointment time and not getting any change in payment as a result of that. And so that's created a real challenge, but also maybe an opportunity for AI to help us better manage patients when they're in the office. The third area I would say is population health, and that came out across really well with the tech companies. Most of the delivery systems are fee-for-service systems. We don't have the tools that you need to appropriately manage patients in the community. The communication platforms are really still suffering from understanding what's happening with patients between office visits. We do a pretty good job documenting what happens when they show up and maybe what happens on a portal, but there's so much more that happens with patients in populations that we don't know about. The fourth area, I think Q mentioned, social determinants of health. When we look at who are the patients that are having the biggest outliers in our hospital costs, or the patients that we feel like we're still underperforming with regard to quality and outcomes, a lot of this gets associated with social determinants of health. And as a delivery system, we don't measure social determinants of health very easily, and we have very little control over them. But from a global health perspective, if we can find better tools and strategies for mitigating the impact of social determinants of health on these patient populations, that will be a big winner. And then the last one I think AI has been working in for a while, but I'll just mention, is misdiagnosis and lack of diagnosis. And that's because we frequently admit patients to the hospital, we don't know what's wrong with them, we run tests, we make a hypothesis, we start treating that hypothesis, and then we see what happens, and then we go to something else if things don't turn out the way you think they're supposed to turn out. And we still, with all the data that we have, we still don't have a good handle on understanding how prevalent and common this is, and what kind of benefits we can see by earlier intervention and treatment by using tools that can give us better predictive ability to manage all of the different data streams that we have to make better diagnosis and make better treatment decisions. And so I continue to leave that on the table because from an institutional perspective, we want to improve our outcomes, and part of that is going to require that we change some of our paradigms around how we diagnose and treat patients. So that's a 30,000 level view of our 5 areas, and hopefully during the Q&A with Ben, we can get into more granular detail about how AI can help address some of these things.
Stay on as well with the mic, and Q, do you want to come back on stage? Great. And you still have your microphone, or you gave it up?
Well, while you're waiting, I think you need a pair of socks. You got to look in the eye.
Thank you very much.
Yeah, I hope to get my pair a bit later as well, but I should go talk to startups since I'm a VC, right? So briefly about myself, my name is Benjamin Levy. I'm a co-founder of Bootstrap Labs. We're one of the early kind of VCs to recognize what was happening in AI and kind of launched the Applied AI Conference about 2 years ago. We are hosting it this year in April 12 with about 800 people. And we're pretty active. We've done about 17 deals in the last kind of year and a half. And we invest in 4 verticals. Healthcare is not the only one we focus on, but we're doing transportation, fintech, future of work, and then health tech. And 2 years ago, we would not touch healthcare, not doing biotech stuff, but we're like, as healthcare became more of a data and software-driven innovation world, it kind of made sense to go into that direction. And as you've seen from the startups on the panel, I think earlier, great data from everybody. Like, the amount of capital that's going into the space, just briefly, $8 billion actually the year before that. In 2017, I think it's about $12 billion going into digital health from the venture capital world. Actually, not surprising to me, but maybe to some of you here, a lot of that money actually is in Silicon Valley. New York second, Boston third, right? Like when you think about this, in stronghold where Boston could be seen as really the mecca of healthcare historically, as things transition to technology, Silicon Valley is becoming more and more of an important place for it, obviously with AI. So I'm very honored, thank you, Dr. Rhee, to have me here again this year, and fortunate to be on stage with you two. I don't think we're going to solve this problem in 15 minutes. As you understood, it's really complex. But I'd like to try to bring some attention to some of the things you said. I love the trust. We totally believe in the augmented intelligence aspects. It's not about replacing human beings. I think technology for a long time will continue empowering human beings, and we might do different things. So I'd like to think about, in your context, right, which is orthopedics, and then we can broaden it up, but you're trying to provide better outcomes ultimately, and understanding the continuum of care of these people. And so where does the AI technology today, when you think about each role inside the organization, is going to be able to help? So maybe we start with the surgeons, like to try to give very practical example as to where AI technology can be helpful to the surgeons, maybe to the people in the back office or nurses, and then in and out of the hospital when it comes to the patients, right?
Well, I think we still make treatment decisions based upon fairly crude data about whether this specific joint replacement or this specific procedure is the right one for the problem that we're dealing with. And part of the factors that come into play aren't only the disease factors, but the patient factors, the environment factors, the social factors. And we don't have tools to help us consider all the different factors that will impact healing and outcomes. And so when we look at outcomes more globally, the treatment is only one piece of that. And so how does AI help us look at that individual patient from a precision medicine, precision outcomes type perspective, and make the right recommendation for the treatment course based upon the totality of their environment, their social circumstances, et cetera?
So I think we've invested in company mental health, and what they're really going after is being able to leverage AI technology to understand the EMR records, the specificity of that patient into the context of cancer to start with, and to match them with the right drug trials, the right development trials that could be the right drugs for them, because chemotherapy is such an old technique and actually trying to kill everything except your cells, right? Do you see areas where AI is really good in specific areas, gathering a lot of complex information that humans have a hard time to, and then maybe figuring out patterns. In that context, do you think we can have AI helping?
Quickly, I want to answer this idea of how do you get to outcomes. So I do think it takes time, and you have to think about it from the core AI technologies first. You have to prove that. I think about how we learned medicine. We learned in terms of the different organ systems, and so we have to sort of prove different core AI technologies. Then you have to prove it works in the workflow and it's usable. I think that's one of the gaps that we've had as we've introduced technology into healthcare. You have to demonstrate then that it actually has a significant impact. And then you can get to the quadruple aim. You also have to build trust with the AI systems, which I like to use the term concordance, that the AI systems recommend analogous to what experts would recommend. So you've got to build that trust before you say man plus machine or woman plus machine. Then you can get into outcomes. We often want to go straight to outcome studies, and I want to suggest that there's much more that you have to do before that. As startups look to prove their efforts, their technologies, you have to start from an earlier stage. Because if you do these outcome studies and you discover it doesn't work, it might be because of lack of usability or integration into workflow. It might be because, but the product is great. It might be because the core technology isn't working. It might be because the doctors didn't trust the system, so they didn't want to use it, even though it made good recommendations. So you sort of need to do these other things. Going back to what AI could be used for, I think a lot of the pattern recognition areas seems to be where there's a lot of growth. You know, looking at how AI, Google put something on, retinopathies and melanomas. IBM has done some stuff on skin. These radiology. There's a lot of work in radiology.
So the vision, right? The vision area, we know there's a lot of improvements, right?
Yeah, and I think there's a lot in terms of. I like to say AI can hear as well. Mm-hmm. Actually, cognitive. Yeah, like Alzheimer's, dementia. There's lots of opportunities as you look at speech patterns that, frankly, a doctor who only sees a patient, once every 3 to 6 months for 7 minutes with that amount of time documenting, huge opportunity. I also think there could be an opportunity to use AI to draft your notes. I mean, I know Nuance and M-Modal, a number of companies are trying to do that, but if we can get to a place where we eliminate that 1 to 2 hours or cut it in half, or the 5 hours you spend documenting your visit, and you can focus on the patient,
Which is not reimbursed, by the way. So you're really the highest paid scribes people in the industry, right?
Yeah, you're right. We're spending all this time scribing, which is in many ways a waste. I mean, it's not leveraging the skills that a physician has. Right. So how do you do that? So there's lots of areas, but those are a few.
But I mean, some people say, look, the diagnosis is not really the issues. Like, it's these conversations. It's almost like conversational health, right? I have these patients. How do I get visibility before, when they're in, and then after, and not just post-surgery, but really these ongoing conversations, right? We see, in the technology world, there's a lot of AI and apply to customer support and customer service where, these conversations are being trained and learned, and so you can engage and educate, to your point, a lot of people about, hey, when is a good time to come in to ask questions or about this pain threshold, right? Or how much pain am I feeling? I mean, can we benchmark that? Do we have more sensors down in and out of the hospitals? We can track that. These, I think, that's areas where AI is going to be pretty helpful.
And I'd say where I've seen us using these applications most recently with success have been mostly in the hospital, helping to make earlier decisions about treatment. So Sepsis Alert, for example, doesn't have a very fancy AI machine learning algorithm behind it, but we've actually reduced the mortality for sepsis in our hospital by using a simple 12-variable algorithm that gets run in the background of the EHR every day on every patient and identifies those patients who are now meeting criteria for treatment. But then if you look at if you actually look at the accuracy of that diagnosis, we're over-treating some patients so that we don't under-treat other patients. That's where AI and machine learning can come in and really help us be much more precise by factoring and taking into account much larger variables. The other place we've been using it is, again, harnessing all the data that's in the EMR that humans are putting into it, and then never get looked at. If you look at the nursing notes, doctors never look at the nursing notes. Nurses rarely look into the doctor notes. In fact, many EMRs are set up to not allow either side to look at the other side. It's crazy. And so what we recognize is the nurses are putting into place lots of different screening tools to help identify patients at high risk for delirium, as one example. And so that we can then put in prevention strategies to prevent delirium. And what we found is that when we look at the nursing notes and some of the other data in the EMR, we can build, through a machine learning algorithm, a much better prediction tool for those patients than the actual screening tool that we were using. And the win-win there is that now we've eliminated, we haven't eliminated people, we've eliminated that work that that person has to do so that they can then focus on other parts of their job, and we can let this delirium prevention screen work in the background.
Right, so unlocking the data, I mean, you know, one of the startups on stage was about trying to create almost APIs to the data so you can start doing things with it. And I think that's a big trend going forward. I think in the banking sector, you see that. I think in the healthcare, you're going to see that, you know, enabling you as providers to have a lot of that data to be unlocked so that you can apply it, right? There's companies like talking about automating machine learning. I mean, one of the challenges today of every corporation, and let alone hospitals, is to get AI experts to actually focus on your problems, right? I mean, the talent access, the understanding of the workflows is a big challenge. I think very few people really understand the challenges inside the organizations and how you match these two together, right, with an entrepreneurial endeavor and spirit. So I think Dr. Binney wants to develop leadership because he wants people within this organization to emerge and rise and say, hey, I'm going to take this initiative to try to figure this thing out, because it's hard from the outside in, right? I think you need an insider's perspective along with somebody that has deep domain knowledge, expertise in technology. I mean, have you hired any AI experts on your tech staff?
We contract more than hire, but you're right. I think we want to embed the AI folks more deeply in the understanding of the problem rather than just the solution of the problem, because I think there's a lot of hypothesis generation that occurs when you look at a problem with AI and with the machine learning, as we're seeing.
So to go a bit more onto the technology side, some of the challenges with AI today that people don't like to talk about, right? I love your expression of a transparent box, right? It's not a black box, but transparent box, glass box. I thought that was pretty elegant. We know today that AI is not really good at explaining itself and why they're doing decisions. Sometimes in such complex environment that as humans we can't even tell, and then a small variation can change the outcome. So do you think the trust level is there to start doing things that in that world is so critical when it comes to implications of decisions?
The trust? Is it the trust there?
Is the trust in the technology? I mean, I think, you know, the technology is really good at discrete things, but I think people are questioning the optimization. What data do you use? If I change the data, is the outcome the same?
I don't think the trust is fully there yet. And I think that's justified. I think, you know, if you think about what physicians do, I'm focusing on a physician-centered perspective. You go through all this training, you go through all this medical school, all this residency, all this debt, all this effort, and you're like, you know, you want me to trust that system to help me do a better job. I'm pretty good. I mean, I work pretty hard. I think I'm a pretty good doctor. Most doctors think they're pretty good.
Sure.
So I worry a little bit about how we frame AI. And I think that's one of the biggest gaps we've had in technology is we haven't, like when you think about the EMRs and things, we haven't thought about workflow or usability. Or the fourth part of the quadruple aim, we focus on outcomes, cost, and patient satisfaction, but not physician satisfaction. And I love the reference to burnout. I mean, if technology truly improves, you know, and addresses the physician issues and prevents that burnout, doctors would adopt that like crazy, right? And they would love it, and they would advocate for it for their patients. They're the most trusted entity, not the other Ps. When it comes to patients, who do patients trust most? The doctor. So it's key to get the trust of the doctor in this system. And I think, and part of my experience in cross-cultural communication, I mean, I worked in underserved settings that were primarily African-American, that were Latino or limited English proficient, or now at IBM I see across the globe. I think one of the biggest challenges I see is that cross-cultural communication between technology and healthcare. Mm-hmm. And that often is sometimes where the tension exists and the opportunity exists as well for better collaboration and better alignment.
If I can just add to that on the trust issue, because this is not a new problem, trust. In the quality world, we've been a common thing to develop our practice guidelines, that you go through a rigorous process, evaluating the evidence, working with professional societies, and you come up with, okay, here's a new standard of care. You put it into practice, and it gets adhered to maybe 50% of the time or 40% of the time. And people sit back and ask, why is that? Why don't you trust the data, or why don't you trust this recommendation? And the reason is that the clinical practice of medicine with the patient in front of you, with all these other factors that I alluded to before, have a strong influence on how you use that tool in practice. And the same will be true with AI and some of the recommendations that might come through an AI approach to things, is that you need to acknowledge how the clinician or nurse or person is working with that information with the patient in the live clinical environment. And that's where the embedded piece of bringing partners in to the live environment and do either simulation and then do live alpha and beta testing leads to a product fit that will get you to market with a much stronger product, I think.
So I want to shift gear a little bit, and what's interesting to me is that we have a lot of very knowledgeable people in the Bay Area, people that are pretty advanced in AI technologies, and yet at the same time, as much as I think we might identify some exciting products here, the first applications might be in places where people don't have access to this technology and doctors, so that it's finally available to people. If you look at what happened with Robot Advisor, which people talked a lot in the fintech world, I mean, at first they didn't invent much, and second, they were really an extension of the markets. Like people on the high end of the market were still getting great advice from a financial advisory standpoint, but it's the people that didn't have access to these fancier reallocation dynamic strategies to manage their portfolio, and now we're getting access to it because it's at a fraction of the cost for pretty good quality. So you see the same thing happening here, where finally technology might be developed here, but actually the first implementations might be in other parts of the world.
I think that's right, and that will develop trust in the stakeholders who are making decisions about whether to invest in that. And it will also, you need to have that data to allow you to develop the value proposition that you need to discuss, that you need to present to folks. And so a lot of times there's a leap of faith that when these technologies are based upon small numbers of patients and they weren't done in your delivery system, they were done in another delivery system. So I think you're right.
So I'll touch on 2 points. I know we're getting short on time, but one is, people will talk about robotic a bit later. I mean, I think you need to differentiate AI and robotics. I think AI is really the brain behind the robots and allowing them now to finally see and understand and talk. Our robots will be doing most of the surgeries going forward, do you think?
I'm not the right person.
I'm actually not the right person to answer that.
Here.
You've got a room full of very experienced surgeons.
And we had a great conversation last night. We talked about this, and I think robots are really good at very discrete tasks, and this is a complex and life-threatening potential environment. And so, in the next 5 years, we're debating whether or not robots will. Let's call it augmented surgery, right? Because it's going to be very much doctors and machines.
Look, a lot of what I'm aware of is, I've seen some of the robotic work, but I personally think the nearest term opportunities in AI are related to where a human cannot read, hear, or see everything. So images, like on radiology images, you can't read all those images that are produced. You can't read all the literature. You can't read all the EMRs for every single patient and know everything by recall.
Absolutely.
And you can't hear everything. I mean, if you look at the science, we often only remember 20 to 30% of what we hear, 50% of what we see, and 70% of what we do. So there's challenges in terms of hearing everything as well. So I think that's the proximal opportunities in AI. As it continues to improve, builds trust with the healthcare system, which is a lot more complicated than building trust in retail or banking or other industries where it's a lot more binary in some of these areas. There's huge opportunity. And I personally think the other area is, this is a simple statistic I used to use when I was working in community health centers. Every doctor generally brought in, who were mostly uninsured, underserved, Medicaid, about $1 million. And then every doctor for primary care at the time was only costing me maybe $200,000. So the majority of my spend, and I only had a 1% margin, so I only had enough money in the bank to really cover salaries for another 3 months, perhaps. The margins were so thin. Ultimately, think about all the other roles, call center roles, front desk roles, all the broad range. There's a lot of other team members who play an important role. We shouldn't only think about how AI will help the doctors, we should think about how it helps the whole team.
Absolutely. I think there's really an opportunity to optimize. I mean, we invested in a bunch of companies that do real-time text understanding. I agree with you, finding the data. I think we're running out of time. We'll get at the end, but I think back to the space in general. I mean, people live longer. They actually going to try to live healthier. We haven't even touched about augmented human beings and some of the potential there. So I look forward to very much this conference growing over time, and a great opportunity in your space. And so I totally understand why we're all here trying to solve this problem. Thank you for your time. Thank you.